Very good evening, student. Today we are on a very important question, and this question is write a short answer. So this is not a short, note. It is a short answer, or you may consider or extend it as a long answer also if it is asked. Write a short answer on mechanism of the respiration. So this mechanism of the respiration I am going to tell you. You can note down with your in your notebook. Introduction, I will just introduce about the mechanism of respiration. Then second point, I will tell you about the inspiration, okay, inhalation, and then I will talk to you about the various dimensions, which are diameters, which increases in the inspiration. For example, anteroposterior, then the transverse diameter. I will talk about transverse, and then I will talk about the increase in the vertical diameter. So this will complete the inspiration, okay, and then I will come to the expiration, okay. After the inspiration, then I will tell you about the expiration, and then the fourth point will be the muscle involved in the quiet breathing, okay, and then the muscle involved in the deep breathing or the forced breathing, and lastly the sixth point will be the applied anatomy. So note down all these points, and now the lectures begin on the mechanism of the respiration. So we come on to the a short answer or a full question on the mechanism of the inspiration. Now in introduction I have to tell you that the respiration which occurs, it occurs in two alternate phases, as you all know. It is the inspiration and the expiration, or inspiration and the expiration, okay. Inspiration means taking the air in the lung, that is inhaling the air, and expiration means exhaling the air from the lung outside, which mostly contain carbon dioxide, while inhaling will mostly contain the air. Okay, so there are two alternate phases. That means they keep on going one after the other. Inspiration is followed by the expiration, and then again comes inspiration. This condition, these two phases keeps on going, and about 16 to 18, and in some cases about 20 breathing takes place in a minute, okay. Now this in inspiration or inhalation we take the air in, okay, and because of this the air goes inside the lung and the lung expand, okay. The lungs, they are sponge like structure which contain multiple, okay, millions of the alveoli or the air sacs, and when air fills in these air sacs, which are called as alveoli, okay, they expand. So the whole lung expand, and at the end of the inspiration, then this lung get retracts when the air comes out in the expiration or exhaling, okay, exhaling. So now the question comes, what causes the lung to expand and retract, okay? Why lung gets expanded and retracted? So for that, inspiration is due to the movements in the thoracic wall, okay. Thoracic wall, you know, it is made up of, as we have learned in the last few videos, the thoracic wall constitute of the skeleton. Skeleton means the vertebral, thoracic vertebral column is there in formation of the skeleton of the thoracic wall. Then there are the ribs, 12 pairs of the ribs are there, then costal cartilages are there, sternum is there anteriorly, manubrum, body, and the gyphoid process. And in between these ribs or in intercostal space, there are the intercostal muscle, external, internal, and innermost intercostal. There are some other muscles also which are attached to the ribs. They are also the muscles which are involved in the respiration, okay. So these muscles, they causes the movement in the thoracic wall, okay, while expiration is taking place. while inspiration is taking place, that's due to the contraction of the muscle attached to the ribs, while when you are exhaling the air out or expiration is taking place, it is due to the recoil, okay, because the lung tissue are highly elastic, alveoli are elastic, so the lung automatically collapses. Passively it collapses. Similarly, the muscles which were contracting, the intercostal, diaphragmatic and other muscles, they will also relax during the expiration, okay. So this is a passive phenomena, expiration. So this is an introduction about the mechanism of respiration, okay. So this is divided into two phases, inspiration and expiration. So we come on to the first phase, and that is the inspiration. So we will learn about the inspiration or inhaling the air, okay, how it takes place. Now during the inspirations, movement occurs to increase the capacity of the thoracic cavity. So our thoracic cavity, which is a cone-shaped cavity, narrow above and broad below, where it is giving attachment to the diaphragm, its diameter increases. So when the diameter of thoracic cavity increases, then only the inspiration takes place. Air goes in our lung. Okay, then question comes, why it is necessary to increase the capacity or volume of thoracic cavity? Okay, it is an important question. Why the diameters of the thoracic cavity should increase so that the inspiration can take place? Now, this is because there is a cavity present on the right side and left side, which is called as the pleural cavity, okay. And this pleural cavity is a closed cavity and it has the negative pressure. What do you mean by negative pressure? Negative pressure means there is no pressure, okay. And whenever there is increase in this cavity which is having negative pressure, then it starts sucking the air because it is negative, okay. So it tries to go towards positive side. That means it tries to suck something because there is nothing inside it, no air, no pressure is there inside this negative pressure of the pleural cavity. Let us see first this diagram, okay. So then you will understand what is a pleural cavity is there. Now this is the trachea, which divides into the right and the left bronchus, primary or principal bronchus, and then this bronchus, okay, they go to the right and the left lung. For example, this bronchus is coming to this lung. This is the outline of the lung where it divides. The bronchus divides into the primary into secondary, secondary into tertiary, and multiple up to 20 times it go on dividing. And then I have shown you with these curved lines the alveoli. So this structure is almost like a sponge where the spaces are there, and these spaces here in lung are called as alveoli, okay, which are the chambers, very small chambers of the air, okay. Air comes in the alveoli and where gaseous exchange takes place. Now this lung is covered by a serous membrane. It is very intense. Just see this green line, okay. This green line is very intimately just covering to the surface of the lung, all the surface of the lung, and this is called as visceral pleura. It is serous membrane, okay, lined by epithelium, which is a squamous kind of the epithelium. Then this serous membrane cannot be separated. It is very firmly attached to the lung, so it becomes the part of the lung. It becomes the part. It cannot be separated from the lung. Then this serous membrane goes on to the surface of this bronchus, primary, with the blood vessels and lymphatics, okay, veins which are coming, and these structures are piercing at the root of the lung. There this pleura, that is called as the visceral pleura, because it is covering to the viscera, that is the lung here. It covers to the root of the lung, where many structures are there. I have shown only one for simplicity. Okay, then after covering to the root of the lung, then this serous membrane immediately will cover to the peripheral cavity, okay, of the thorax, and this cavity will be on medial side formed by the mediastinum. So this pleura which is covering to it will be called as mediastinal pleura. Then it will cover to the apex, so apical pleura. Then it will cover to the ribs and intercostal muscles from its inner aspect. So this is called as the costal pleura, because it is covering the ribs and intercostal spaces. And then it will cover to the upper surface of the diaphragm. And what is diaphragm? Diaphragm is a muscular separation between the thorax above and abdomen below. So it will cover to the diaphragm, and diaphragm here is the dome of the diaphragm, which is centrally attached to a central tendon. Okay, so this cavity which is present between the parietal pleura and the serous pleura is called as pleural cavity, and this has a negative pressure. Okay, there is a negative pressure which is present, and during the act of inspiration, when this dimensions or diameters of this cavity increases, thoracic cavity, this also increases the diameters of this pleural cavity. Okay, I have shown a lot of the space between the parietal and the visceral pleura for you to understand, but the spaces are only near the diaphragm, that is costodiaphragmatic recess and costomediastinal mediastinal phrenic recess, which is here. They are there. Otherwise, now there is not much space. Okay, not much capillary space is present here. Okay, so this when the dimensions of this cavity will increase, okay, in various direction it can increase. It can increase in the anteroposterior diameter can increase, okay, from front to back. Okay, anteroposterior diameter of thoracic cavity can increase. This will increase the anteroposterior diameter of pleural cavity simultaneously. Then this diameter can increase in transverse direction. See, this is the transverse direction. Okay, from here to here, this is the transverse direction. So it will increase in transverse direction. Okay, then this can increase in the vertical direction. So this is vertical. So in three different directions the cavity can increase. That means the dimensions or diameter of the cavity can increase in three different directions. It is anteroposterior, it is transverse, and then it is the vertical direction. When during the inspiration, thus the capacity increases due to the increase in three dimensions or three diameters, then an negative pressure is generated, further negative pressure is generated in the pleural cavity, which help to suck the air within the lung through the nose and then trachea. Okay, nose, and then it comes to the larynx, and from larynx to the trachea. Thus, during inspiration, it is the increase in the dimensions of thoracic cavity in the different diameter which helps to increase the negative pressure in pleural cavity, and that sucks the air. Okay, so what is important for the phase of the respiration, which is called as the inspiration or inspiration? This is necessary to increase it is necessary to increase the dimension of this cavity. Okay, dimension of the thoracic cavity. Okay, follow this. Okay, so now we are, since on inspiration or inhaling, okay, where the air is being inhaled, I will reduce it. Okay, air is being inhaled, so that during this inhalation, okay, or inspiration, let us see how these three different dimensions are increased. That is important in the mechanism. Okay, how these three important dimension, that is anteroposterior diameter, transverse diameter and vertical diameter of this thoracic cavity, thus the pleural cavity increases. Okay, because this will help to suck the air inside the lungs, so the inhalation will take place. Let us come first, okay, on to the anteroposterior, increase in the please keep on noting in your notebook. Okay, increase in the anteroposterior direction or diameter, okay, of the thoracic cavity. Now this increase in the anteroposterior direction is due to the movement. As I said, all the movements which are taking place in the thoracic wall, they will increase. And how the movement takes place? For movement it is necessary for the muscle to be presence of muscle and bones, so that when muscle will contract, it will move the bone there. And bones, I have already told, are skeletal framework of the thoracic cavity. I have told you what are those. So the movements occurs in the ribs, and these ribs are vertebro-sternal ribs. Okay, so anteroposterior diameter increases because of the movement in the vertebro-sternal rib. What are vertebro-sternal rib? Which starts from the vertebral column behind, okay, thoracic vertebrae, and goes right up to the sternum, okay, to the body of the sternum. And these ribs are 2 to 6 ribs. So rib number 2 to 6 are called as vertebro-sternal rib, and when the movement will take place in this 2 to 6 or vertebro-sternal rib, then the anteroposterior diameter of thoracic cavity will increase. Let us see the mechanism. How the anteroposterior diameter will increase due to the these vertebro-sternal rib are 2 to 6 ribs. Now, if you will see these ribs, I have tried to show you in this diagram. Let us concentrate on this diagram. The anterior end, which is with that of the this is what? This is the costal cartilage. Okay, so the anterior end of the costal cartilage here, this is the anterior end of the costal cartilage. So I am just drawing it with blue, which is attached to the lateral margin of the sternum. Rough diagram, okay, lateral margin, because it is the vertebro-sternal rib. This is the posterior end of the rib, okay, which is the head of the rib articulating with the body. Then it articulates at the transverse joint, costo-transverse joint, and this is the costo-vertebral joint, okay, which is the posterior end of the rib and anterior end of the rib. Now anterior end of the ribs here in this movement, okay, it moves upward and forward with the sternum. And why it moves upward and forward with the sternum? Okay, because the two ends of the ribs, see this posterior end at the costo-vertebral joint and the anterior end, which is forming a joint with the sternum, they are at two different levels. Posterior end is at a higher level and anterior end is at a lower level, and the rib forms a curve, okay, on one side of the thoracic wall or chest wall, okay. Now, because of the contraction, and contraction will take place, why? Because the intercostal muscles, they will contract, all three, okay, external intercostal, internal intercostal and the innermost intercostal, mainly three muscles, they will contract and pull the lower rib upward. So it is the elevation of the ribs. From 2 to 6 ribs, they will be elevated on right side as well as on left side in the act of the inspiration or the inhaling, okay, inhalation, okay. Now, because of this lifting of the ribs from 2 to 6 number, the anterior end of the rib will move upward. See this, I have shown you in dotted line. Okay, after contraction of the muscle, the rib will move upward, especially the anterior. Maximum upward movement will be towards the anterior end. Okay. and this will move not only upward, but this will also move forward. Okay, so the sternum at the manibro-sternal joint, which is a symphysial joint. At this joint, the body of the sternum will be pushed forward, okay, and little upward. So forward and upward movement will take place in the sternum, and as you know, the body of the sternum gives attachment to the second to the sixth rib. Seventh is at the junction of the xiphoid and the sternum. So we are talking of the second to the sixth rib. Will just now because of this, see, the previously the sternum body was lying at this level, and because of the lifting of the second to sixth rib, now the sternum has moved, and the movement has taken place at the sternum manibro-sternal joint. So this much of shifting has taken place, and because of this much of shifting, forward shifting, the antero-posterior diameter of thoracic cavity will increase on right side as well as onto the left side. Thus the pleural cavity, which has the negative pressure, will also increase in the antero-posterior diameter. Okay, so thus there is an increase in the antero-posterior diameter. I hope that you have understood this. And why this is taking place? Because I said contraction of the intercostal muscles. Okay, intercostal muscle, the contraction is taking place. Thus the antero-posterior diameter is taking place. Now, since the sternum is moving up and down, okay, means forward and backward here, in this case, forward and backward. This is similar to the pump handle movement. Which pump? The pump means which we I mean to say in the bore wheel, okay, which is fitted and which is manually operate. You just move the handle which is horizontally placed up and down, so the water is start coming here. But here it is not an up and down, here it is antero-posterior movement. So but it is something similar to the pump handle movement. Okay, even if you forget the pump handle, try to remember that mechanism, okay, this mechanism, and basic reason for upward, forward thrust or movement anteriorly is because of the difference in the level of attachment of the posterior and anterior end, and when the rib will try to go upward, elevated, okay, because of contraction, it will push the sternum forward, okay, thus increasing the antero-posterior diameter. Okay, now since the rib is going from posterior to anterior side, and it has to be elevated. How many ribs? 2 to 6. At the same time, since the ribs is elevating up, okay, from inferior to the superior side, which was a chord structure. See here in this diagram, this was the original rib here, which whose shaft was at a lower level. Because of the elevation, okay, the rib will go slightly outward also. That means not only the antero-posterior diameter will increase due to the contraction of the intercostal muscles between 2 to 6, okay, or vertebro-sternal ribs, but at the same time it will also help to increase some transverse direction. This is important, okay, right? So this is, we have completed the first aspect of the increase in diameter of the thoracic cavity, that is the antero-posterior diameter, okay, antero-posterior. Let us come to the second aspect of the increase in the diameter is the transverse diameter, okay, transverse diameter. That means from side to side, how the transverse diameter will increase. Just see this diagram here. See, this is the body, transverse process, head of the rib, the body of the rib, and this is the sternum. And when this rib is elevated, okay, then it goes outside, and thus it will increase the transverse diameter, okay, transverse. Let us understand transverse diameter. Second mechanism by which the thoracic cavity dimensions will increase. Now this movement occurs at the vertebrochondral ribs. And which are the vertebrochondral rib? From 7 to 10. And why they are called as vertebrochondral? Because medially they are attached to the vertebrae, and anteriorly they are attached to the costal cartilage. Of course, seventh is attached at the junction of Gibbite process with the lower end of the body of the sternum, but others, okay, that is 8, 9 and 10, they just join each other, okay, at the chondral, and they just join to the cartilages, not to the bony sternum body of this. That's why they are called as vertebrochondral ribs. So from 7 to 10 ribs, when they are lifted up, and lifting is because of again contraction of the intercostal muscles, okay, all three muscles will just lift this 4 ribs here down below, okay, which are the lower ribs here, and because of that the rib will go up. Why they will go up? Because see in this diagram, okay, the middle part are sharp. This is slightly anterolateral diagram, just I have drawn to show you that how the lifting or elevation of the rib will increase the dimension, okay, it will increase the dimension, that is the transverse dimension will increase, okay. Now because of the lifting, the middle part of the shaft lies, okay, at a lower level. So the middle part of the shaft here in this transverse, you can also see the middle part of the shaft lies at a lower level as compared to its two ends, that is vertebral end and the sternal end. This the shaft lies at a lower level. When you will see the skeleton, okay, articulated skeleton in dissection hall, try to understand this lower level. This definitely at a much lower level than either its vertebral or the sternal end, okay. So this will be lifted up. That means the shaft part of the rib will be lifted up, and because of the lifting, the transverse diameter of the cavity, thoracic cavity, will increase, and thus the pleural cavity dimensions will also increase, okay. And when this rib is elevated, this will go outward, okay, so thus increasing the transverse diameter, okay, necessary, okay. Now this movement is called as bucket handle movement, which you can understand. Compare these two diagram here, this diagram with that bucket. Now this is the bucket and this is handle, okay. We lift first this handle so that it comes to the horizontal position. Once now here, say for example, this is the vertebral end and this is the sternal end, and this is the rib, which is shaft of the rib, which is at a lower level. When you lift this, then this handle goes outward, which was otherwise, okay, at a lower level. Thus from the midline it was close, but when you lift it, it will go away from the midline. So this much of the dimension change will take place when the handle is lifted. Similarly, when the rib will be lifted up, this much of the dimension will increase, okay, and this is taking place from 7th to the 10th rib. So all those 4 ribs, they will go outward, thus increasing the transverse diameter. So remember that this bucket handle movement or the pump handle movement, they are taking place simultaneously. It is not that first the bucket handle will take place or first this pump handle will take place. There are all 3 dimensions, they are increasing simultaneously because the muscles are contracting simultaneously. Intercostal muscles, they are contracting, and this is due to the position of its posterior and anterior end and the position of the shaft in the lower ribs, and there it was, okay, because of the posterior end and the anterior end was at a higher level, okay. So that was the increase, it was, I mean to say, pushing the sternum forward, okay, and thus increasing anteroposterior, and here the shaft is increasing up, I mean to say lifted upwards, so that transverse diameter is increased. I hope that you understand both the anteroposterior and transverse dimensions. Okay, increase in the transverse dimension. Okay, let us come to the third parameters which will increase the vertical dimension of the pleural cavity or the thoracic cavity. You see here, this is the vertical dimensions. Okay, I have just drawn a very rough diagram. You can also just very quickly draw. This is the diaphragm, and diaphragm is a muscular tendon. This is tendon, central tendon of diaphragm, drawn in blue color, and this is muscle color. Okay, this is the right dome of the diaphragm, this is the left dome of the diaphragm, this is central tendon. Above this diaphragm is thorax, which contain the heart in center, left lung and right lung, and this is the thoracic wall with the intercostal muscles and the ribs, right? Just very simply drawn. And below the diaphragm is the abdominal cavity. Okay, this is the abdominal cavity. Now this diaphragm is a muscular partition, as I said, between thorax and abdomen, supplied by the nerve called as the phrenic nerve. Stimulation of the phrenic nerve causes the contraction of this diaphragm, muscles of diaphragm. So the central tendon is pushed downward because of the contraction, and then this dome of the diaphragm, which are convex upward. See this convex, here will be lever, it is still more convex, but for simplicity I have just shown the little convexity upward. This diaphragm will come down, and this muscle and tendon will go down, and then the dome will become flattened. Okay, see this, which was convex upward will be slightly less convex now, and lever will go down. Okay, it will push the lever, and on this side stomach and spleen, they will go down. Okay, so this will be increasing the dimension, vertical diameter, because of the downward movement of the diaphragm. Naturally the vertical diameter of the thoracic cavity will increase. So this is very simple. Okay, it increases due to the contraction of the diaphragm. So now these are the three different mechanisms by which the dimension will increase. Anteroposterior, by movement of the body of the sternum forward, so anteroposterior. Transverse, by lifting of the shaft or middle portion of the rib upward, and here the vertical by the downward movement of the diaphragm. I hope that you have understood all three. Okay, increase in diameter in three different directions during the act of inspiration. Okay, or when you are inhaling the air. So muscles are active, muscles of the intercostal muscles and the diaphragm. Okay, and mainly diaphragm. Now this completes the inspiration or inhaling, and now we come to the expiration. Okay, now in expiration what will happen? Okay, now this is a passive movement. You don't need any muscle to contract. Okay, it takes place passive means it takes place automatically. Okay, once the inhalation is over, that means inspiration is over, then what will happen? The lung will try to collapse. And why the lung will collapse? Because as I said, the lung is very elastic. It is made up just similar to the sponge. So the air filled in the lung alveoli, okay, it will try to go out, come out. So and this will be because of the elasticity. Similar to that, when you stretch a rubber band, then it goes stretch, and when you releases the pressure, then immediately rubber band comes to the normal position. In the similar way, this is elastic recoil of the lung is responsible for the expiration. Okay, another factor which is necessary for the expiration is the intercostal muscle and the muscles of diaphragm. Now they start relaxing. Previously they were contracting. Now they have started relaxing, and because of that, okay, the air will go out. Okay, air will go out from the lung. So these are the two mechanisms by which the expiration or exhaling takes place. This completes the inspiration and expiration mechanism, okay, in the mechanism of the respiration, okay, mechanism. Let us come in the next point is the muscles involved in the quiet breathing. When you are sitting, we are not doing anything, okay, then you are having the quiet breathing. You are not aware about your breathing. It is automatically taking place, and this is the quiet breathing is because of the contraction of diaphragm. Most important feature in the quiet breathing is that at a regular interval, okay, your muscles of the diaphragm are contracting, so the vertical dimension is increasing and air is sucked, okay, air is sucked. Now this is the main muscle for the respiration in the quiet breathing, right? Diaphragm, which is supplied by phrenic nerve. But at the same time, intercostal muscles are also playing some part in the quiet breathing. They are also contracting and relaxing, but not major thing is because of contraction, okay. And this contraction of these two different muscles, it result in what? It result in increase of the vertical diameter, because diaphragm is going down, so vertical diameter is increasing by contraction of diaphragm. At the same time, transverse diameter is increasing by elevation of the 7th to the 10th rib, okay, vertebrochondral ribs. And similarly, anteroposterior diameter is also increasing by elevation of the vertebrosternal rib, that is 2 to 6 ribs. That means from 1st to the 10th rib they are elevated, right from, sorry, not on 1st, 2nd to that of the 10th ribs, they are simultaneously elevated by contraction of the intercostal muscle, and the diameter vertical is increased because of the diaphragm, right? I hope you understood. Let us come to another kind of the respiration where muscle involved is which are the muscle which are involved in the deep breathing, okay, deep breathing, when you have to take the deep breathing, or sometimes still further when you have to take the force breathing, okay, forcefully you have to take the breathing as you are doing the running for a long time and other exercises, you will have to do the deep breathing and force breathing. Now first, the deep breathing is because of all muscles of quiet breathing will be active, okay, and they will active, their movement will increase in the deep breathing. All those means diaphragm and intercostal muscle. Now since you are doing some exercise, they will be powerfully contracting, and their speed will also, respiratory speed will also increase. But when you are doing the force breathing, okay, then in that condition, right and left scapula are fixed, okay, both the scapulae are fixed by which muscle? A trapezius, which is attached to the medial, the spine of the this scapula, the trapezius, rhomboids, which are attached to the medial border, levator scapulae, which is attached to the upper border of the scapula. All these muscles, okay, they are contracted. They will contract very vigorously so as the scapula cannot move. Scapula remain pulled towards the medial plane, okay, median, because they are all onto the medial side. So now since the scapula is fixed, so the other muscles, okay, which are attached to the ribs, say for example serratus anterior, you have seen the 8 digitation of serratus anterior, okay, all these which are taking origin from the side of the rib cage, okay, side of the rib cage, and then this is going towards the medial border of the scapula. So since the medial border of the scapula is now fixed, okay, now serratus anterior can move the ribs, okay, because its origin is, its insertion is fixed, and its origin from the ribs can move, so it can also elevate the ribs, so it will also helps to increase the transverse and anteroposterior diameter. So but this muscle will come in action only when you are having the force breathing. Similarly, because of fixing of the scapula, pectoralis minor, which is also attached to that of the chest ribs onto the anterior aspect, that will also start acting on the ribs. Okay, it will also increase the dimensions of the thoracic cavity. Okay, thoracic cavity. Similarly, the first rib can also act here. Okay, the forced breathing due to the attachment of the scalene anterior and that of the medius. Okay, scalenus anterior and medius. Okay, otherwise the first rib doesn't take part in the respiration. Okay, because it has to keep the manubrium sterni fixed. Manubrium sterni, so that the movement can take place at the manubro-sternal joint, as we have seen in the for the movements of the vertebro-sternal and vertebrochondral ribs. Okay, vertebrochondral. Lastly, we come to the applied importance of this respiration. Okay, the mechanism which we have learned. When a patient feels difficulty in breathing, he feels comfortable. Okay, whenever you will go to the hospital next year, then if you try to see the patients, those who are suffering from asthma disease where difficulty in breathing is there, they are always air hungry because their bronchial tree, okay, muscle, sympathetic supply to this smooth muscle, okay, it is smooth muscle are contracted, so the air passage is narrow and they are hungry for the air. These patients, okay, you will find them, they are always sitting on the bed. Okay, in the ward they will always sitting in the bed. Okay, and they are leaning forward, they are not sitting straight, but they are just bent forward, they are leaning forward and will try to catch some fixed object on the bed. Okay, it may be just the border of the bed. Okay, or it may be some object which they will fix, so and they will hold this object very firmly. Okay, because they want to fix their arm, thus they want to fix the scapula. Okay, so right and left scapulae, they are fixed now, and thus the muscle, the serratus anterior and pectoralis minor, it will also be helping in the inspiration. Okay, it will be also helping in increasing the dimension. While he is sitting up, while the patient is sitting up, this is the most comfortable position because the diaphragm here in this position will go down. While you are lying down or sleeping on the bed, diaphragm is up, and then the dimensions of the thoracic cavity are less, and since you are air hungry during asthma, okay, this position is not, so the patient will immediately, as soon as he will get the asthmatic attack, he will immediately sit on the bed. Okay, immediately sit and start the breathing forcefully. Okay, where all other muscles will also be active. Okay, thank you very much for watching this video.